Good evening, everyone. My name is Ayat. I am one of the moderators this session. Welcome for our third session of the START series, focus on handover practice tips that organized by the British Sudanese Association of the Paediatric and Child Health. Handover is the cornerstone of the safe and effective patient care, ensuring seamless communication during the transitional and minimizing the error. This session will not just involve talk. It is designed to be interactive and practice focused, as we will have the 3 practice handover sessions. The first one will be demonstrated by our 2 consultants to give us a clear example of what will be the effective handover tips. The remaining 2 will be involved 2 volunteers, and that Buran will be practice this handover and receive a feedback to help everyone learn from their experience. Tonight, we have a privilege of 2 pediatric consultants with us today, and they will share their insight, strategy, and real pediatric tips to help us with the handover. Our first speaker is Dr. Nadir Kiddo. He's a pediatric consultant working at UHNM, Royal Stock Hospital. He's organizing the pediatric teaching program there. He's not only an excellent clinician, but he's also been an instrument in supporting a large number of IMG doctors in starting their training by offering mock interview session and tips. Trainees frequently describe him as extremely supportive, approachable, and passionate about teaching. Our second speaker is Dr. Rawia Eltahir, a neonatal special interest pediatrician based at Russell Hall Hospital. She has recently completed her pediatric training in the West Midlands, and she's not only an excellent pediatrician also, she is a very supportive and helpful consultant. She has helped many pediatric trainees through their career and by providing valuable advice and tips, one of them me. On behalf of everyone today, I would like to thank both of our speakers for taking time to give us this session today.
Oh, thank you, Ayat, for the lovely introduction. I've heard a lot of nice words about me, and I'm very privileged to be here today. As you know, as Ayat have introduced, I'm a pediatric consultant at Royal Stock University Hospital. I also finished training recently. Rawia have finished training before me, and we've both been trained in the West Midlands Deanery.
Thank you, Ayat and Nadir. Thank you, everyone, for attending today. It's quite different session today to the previous 2 because we are going to focus on practice, as we said. I'm Rawia. As they just mentioned, I've done a START within the last 2 or 3 years, within the era of doing the START online, kind of the same as you are going to do it. Obviously, it's 10 stations. It's 4 minutes for your reading the station, and then 8 minutes for your practice. So we're just trying to do it exactly the same way, and we try to demonstrate what we think is the best way of doing it. Thank you, guys.
Okay, I'm gonna start the slides. Me and Rawia will share the presentation, so we might chip in. We might do it like a double act today. So sometimes I will speak, sometimes Rawia will speak. So just to let you know, this is the overview of our today's session. So as Rawia mentioned, we're gonna just go quickly through the station structure. We're gonna do the demo scenario. So I will be the assessor. Rawia have happily volunteered to do the candidate or the participant. After that, we're gonna just discuss some few general tips that we think that it's very important. And then I would thank Anzad and Buran, who both have kindly volunteered to do these sessions, and we're gonna try our best to give a positive feedback and then to give you some tips how to go through these scenarios. So let's start with the first part of the teaching today. So as we all mentioned. I think Nadia have mentioned that, Hani have mentioned that, and Rawia just mentioned. You've got a limited time on each station. So when the station starts, you've got 4 minutes to read the scenario, whatever the scenario is. So we're gonna just focus today on the handover. As you're gonna see on these sessions, 4 minutes are very, very short to read your scenario. We'll give you tips how to do that, but you only have 4 minutes. And Ayad, please, when we start the session, please time it so we need exactly 4 minutes, and then we're gonna start the scenario. On the actual body of the scenario, where you're gonna start talking, you have 8 minutes to discuss your strategy to go through the handover. You will have 1 minute warning before the end. So 7 minutes talking and then 1 minute warning before the end, so to start wrapping up. Most of these scenarios in start session is a monologue, so no one will interrupt you. You will just be talking unless you finish early on, and then they will start asking you questions. But most of the time, you will feel like you're just talking to the audience or the assessor, and they're not gonna reply to you. And then you're gonna move after the 8 minutes to the next station. Okay, the scoring in all the stations depending on these criteria. So this is on the RCPCH website. There is also a nice YouTube video about the start session for the assessors. You can go and review that. These are the areas that they look at during the assessment, and they decide how to give you the feedback and to score you. So just be mindful that they are looking at all these things during your talk and the session. And if you miss one of two, they're gonna write it back in the feedback, and then you're gonna need to talk about it in your remediation. Okay. So I think next we're gonna start our scenario. Are you ready, Rawia?
Yeah.
I will start the time now, 4 minutes.
Start 4 minutes for Rawia.
4 minutes start.
So
just to highlight that we are given the 4 minutes so everyone else can also read the scenario and put themselves in a real life of how they're going to do it if they were to be tested.
So there's two folds of the scenario. The first bit, usually it's exactly the same. So it will tell you that you're a newly appointed consultant. The task is to manage your team, the strategy to manage your team, and then they will give you a scenario. And then the next page, it's your actual patients. So in this scenario, you're not on call, but your colleague has been sick. You were in clinic in the morning, but you agreed to step in because no one else can cover the wards, and it's a patient safety. Your team is waiting for you in the morning handover. You've got an ST1, an ST6, and a ward nurse. There is a medical student also present there. And the next handover sheet is being presented to you, which was done by the ST2 who was covering the night. So just have a look at this list of patients.
Again, reading the instruction is your responsibility, and it is within the 4 minutes. So that's make sure that you read the instruction quite in details, because some of the instructions within that is going to be affecting the way that you get to discuss your management.
4 minutes left. 4 minutes finished, sorry.
Okay, so the assessor will come and introduce themselves. Hi, Rawia, this is Nadir. I'm your assessor today. You have read the scenario. Please talk to me through your handover station and tell me how you're going to manage this this list and this handover.
Hi, Nadir. I've agreed to cover for my colleague who is absent, assuming before 8 o'clock handover, 8:30 handover, I have managed to arrange and rescheduled my day. I understand that I was supposed to cover the clinic today. So I'll just go with my secretaries through the list of the patients, making sure that some of them can be rescheduled or cancelled, and some of them, if they are urgent, to be kind of squeeze into other consultants' clinics if possible. And then walking to this 8:30 o'clock handover, just quickly knowing my team. So I've got an ST1 and ST6. I also have a medical student with me today, making sure that they take them round and give them the opportunity to take history and discuss their findings with me. And I've got a ward sister as well. So I would like to start with talking to the ward sister for a quick safety huddle. That would include medical staffing, nursing staffing, capacity, any patients outside the ward, like an ED or PAU that's waiting to come, any incidences overnight, any equipment issues or any other concerns with the staff safeguarding or incidences. Going through the list of patients I've been given, just before, ideally, I would take everyone within the team for a proper ward round. However, before I do that, I'm a bit worried about Amy, who is newly diagnosed diabetes, and she is still on acute DKA. So I need to see her first. I need to make sure that the DKA plan is in place. And I'm also mindful of Dalgender, who is suspected to have a hematological malignancy from reading through the investigation findings and expectations from the night team. As I said, I'll take everyone round with me, including my ST1, ST6, and the medical student. I'll try and make sure that the medical student can find somebody to take history from. I would like to see everyone who's been admitted within the last 24 hours and they haven't seen a consultant, ideally. But some of them, they will end up seeing my juniors first and then me after that. As I said, so Amy is a 6-year-old who is being recently diagnosed with diabetes and admitted within the last 24 hours, and she is still in DKA. Her pH is less than 7, so I'm quite concerned about her. I need to make sure I reviewed the DKA pathway, and I make sure that has been highlighted to the HDU team. I would ask my ST6 to hand over to the HDU team and possibly ring also the diabetes team. Regarding Dalgender, the history is quite concerning. They are still having bruises and splenomegaly, and the findings of blast are quite concerning. So the paramount important in this is to confirm the diagnosis. I need to speak to the tertiary unit about them, and I obviously need to break the bad news to the family and the child. So I need to make that in a controlled way, make sure that I've got the ward sister with me. I've got, if we've got any special interest consultant within the team, that will also be an important asset for me. Jamie, who is a 1-year-old, who is awaiting to see the surgeons, they've got burn. I need to make sure that there is no safeguarding concerns there. So if I send my ST1 to take history, maybe possibly with a medical student, and I also need to make sure that the pain is under control because they're going to surgery. So I'll work with my surgical team regarding these two main aspects. There might be no safeguarding there, and if we are happy with the history, that would be the end of it, and then we'll help with the surgical team regarding IV fluids and pain management if required. Daisy, she has lost weight and she's also hypernatremic, and she's got jaundice that I need to make sure that is being plotted correctly. It doesn't sound like she'll need phototherapy, but I'll need to plot that. And also, I might ask my ST6 to assess her fully just to make sure that there is no possible infections or infection concern. The rest of the patients, I've got Freya, who is a 2-year-old, needs to be assessed for the need for any IVs, antibiotics or IV antivirals because of the new rash. So that's also going to happen during the ward round. And if that is a concern, I would ask my ST1 to see if access is going to be possible or whether that's need to be escalated. the 6-week-old Reem, who's got bronchiolitis. I'm less concerned about her. She's been there for 3 days. So my ST1 can see her, and I'll join for the daily review. She's still on oxygen, so she's not going anywhere. And then I've got the 4-year-old who's got a fever and vomiting. They looks like they've got UTI, and the treatment is waiting to be initiated. So that's antibiotics needs to happen. I need to check whether I've got any organisms or any feedbacks from the labs. And as I mentioned already, Dalgenda needs a bit of work. There is a lot that needs to happen for this child if the diagnosis is to be confirmed. And the tertiary unit needs to know early, and they would guide us through the IV fluids, whether needed or not, and the rest of the medical treatment. And I understand that the communication is really important in here. Generally, I need, once I've gone through this list, I need to organize my day with my team, just have a kind of general plan of how I'm going to go through the ward round, slot some of the jobs into a schedule. Some of them might happen in the afternoon, such as communications, teaching for the diabetic child and communication with their parents.
1 minute left.
Okay, and the possible safeguarding. Once I've done that, I need to ask, just check with the night team that they're happy and they can reach home safely. And then just to highlight any teaching or assessment opportunities for my trainees and for my medical student. And just as I already mentioned, the ward sister needs to be involved with the ward round, go around with me and highlight anything that needs to happen as an MDT for the rest of the day. Thank you.
Thank you, Rawia. How many seconds left, Ayat?
18 minutes. 18 seconds, sorry. Yeah.
So that will not give the assessor enough time to talk to you or ask you a question. I can't say that you have done this before, Rawia. You've used all your time. So if she gave me a bit of time, I would have started asking her, like, just to check her knowledge and her understanding and her complexity. But Rawia didn't give me any time, so I think that's it. Because if the assessor start asking question, the station will finish and she will move on. There's no wait after the 8 minutes. So in this scenario, the assessor might ask you about the complexities that can arise is, for example, they might drop something like, Jamie, you send the ST1 and here the history is very suggestive of non-accidental burn. What do you want to do? And then Rawia will elaborate about the safeguarding procedures and how to inform the safeguarding team and call the social services and then take consent and go through the things. They might also, if they've got time, they can speak about that. Rawia have mentioned that the DKA patient is going to need to go to HDU. They might throw that you are in a DGH, you don't have HDU. How are you going to organize HDU bed? What are you going to do? What are you going to do to safely manage the patient until you speak to the transport team, this and that. So these are the things that you might get if you've got more time with the assessor. Okay. So
thank you, Nadir.
no
Just
problem.
one question. Can we ask about more details? For example, the DKA. Can I ask? Is it the first? Put it here. It is initial pH 6.9. Can I ask recently what happened or what is the blood gas now, because it can show me is it still in the DKA or not, or it is not allowed to ask a question.
Just to let you know, yeah, most of the start assessment will be a monologue. So if you start asking question, you're going to lose time on your actual station. So if you start asking question, that out of your time and you're not going to address everything. So I think don't get involved in lots of details. It's mainly about, so if you go back to the question here, so if you read the task, discuss your strategy for how you would manage your team, not your patients. Okay. So I think what you need to do is they're not testing your clinical knowledge, because you've been a trainee, you are like ST6, ST7, so you've done this for a long time. They want to know how you're going to manage your team. They want to know if you are day one consultant, you're going to have good management plan for everything, okay? So I wouldn't ask more details. I will just go with the details that I've got, and then you're going to need to mention all the options, all the scenarios. You don't need to leave anything for the assessor to penalize you on, okay? So this is what we're going to talk about just after this handover, this session. So all the start assessment scenarios, you just need to forget that you are a trainee now. You need to think, you need to put your shoes in a consultant place. So you need to speak from a consultant point of view. So just imagine that you with trainees, and I'm still a new consultant. I still have the habit that I need to do everything myself. So with consultants, it's more important to manage your team and to delegate and try and make sure that everyone knows what they are doing, okay? As you have seen, 4 minutes might be long. It's not long. You felt it long. The problem is, on the heat of the moment, and you not handover might not be your first session. You might have another session before. You might have been upset by something that you might have missed, or this and that. 4 minutes will be little. You might have more patients. So sometimes they give you 12, 15 patients, very long list. So please don't read all the information. Try and screen and scan, and see which patient you want to prioritize and which patient you are less important. All patients are important, but what I mean is which patient you're going to see yourself, which patients you're going to delegate to others, okay? As mentioned on this slide, all trainees will get John Pete's handover, except if you are grid trainee. If you are a grid trainee, you're going to have the handover with some of your relevant subspecialty, okay? As we said again and again, time management is very important. Try and not to let anything slips. Try and cover all the bases. And if you've covered everything, that's fine, that well and good. If you've got more time, the assessor will start asking you questions. Don't worry about that bit, but try and use all the time that you can, okay? With all the start scenarios, patient safety is very important. So when you talk about everything, as Rawia mentioned at the beginning, yes, she was thrown to the handover station, and it was about handover, but she knows that she has also patients in her clinics, and these patients were coming to see her. And some of these patients might be urgent referral, and you need to see them urgently. And they might not have any slot for the next 2-3 months, maybe, with the NHS pressures. So make sure that you put the patient safety as a paramount. So clinic patients and ward patients. You need to have lateral view. So you need to have a helicopter view. So you need to look at everything underneath you. So as Rawia mentioned, it's not only about the ward. She wanted to know about the incomings. She wanted to know if there's any TCIs coming from other hospitals, anything that been mentioned. And that makes your day easy, and it makes you manage your patient safely. Safety is also about staffing, so you need to make sure that your night team is not exhausted. You need to make sure that if someone is driving long distance, they need to rest. You need to mention all these things. So all these things will give you brownie points. And make sure that you know your team. So as Rawia mentioned at the beginning, go and find out what you can do. Are you happy to do this? Are you happy to do that? And delegate the jobs according to their skill mix, okay? If there is any risk concerns when you're talking to people, if there's any problem with staffing. So in this case, your consultant is off sick, the consultant who was supposed to be covering. So at some point you need to speak to the management and see if this long-term sickness, if there's any cover for tomorrow, if there's any cover for the night. So you just need to cover your bases as well, because you never know. You might be this might happen again tomorrow, and then you cancel another clinic. So you just need to look forward as well. And see if there's any problems with bullying, harassment, other things that you need to know. And in this scenario also, we talked about safeguarding. And as Rawia mentioned, so the medical student will get some teaching. The trainees should have CBDs, many fixes, whatever. If there's any teaching opportunity that arises, you can just provide it to them. Okay. So
if you
any
allow me,
questions
Nadir,
so far?
just
Sorry.
going to add one more tip that came to my mind while I was doing the scenario. Try not to fall into the trap of talking a lot about clinical management of one patient. Just remember, they are not testing your knowledge. If you find yourself talking about one patient too much, you are losing time and you're losing your helicopter view. So when I start talking about the DKA, I don't need to mention about the management of DKA. I just need to point out I've got a DKA pathway. I know that my ST6 knows it, and they just need to go through. I need to double check that. But if you start talking about DKA, then you are going to miss the other 7 patients, and then you are going to miss your closing of everything and making sure that your the rest of the day is being planned. So it's very easy to happen that you slip into that trap, but just to try and stop yourself from talking about one patient.
Thank you, Rawia. Any questions in the chat, or anyone have a question before we start the practice sessions?
There is no question in the chat, but if anyone have any question, please unmute yourself and feel free to ask.
Hi, can you hear me?
Yeah,
Yeah,
go
hi.
ahead.
Hi, my name is Nadia. Thank you very much for this session. Well done. I'm impressed. I know, I just want to make sure, are you suggesting that we actually should use all our time and not leaving any minute for the assessor to ask us question, or is it better to actually leave a bit of time for them?
I would say there is no right and wrong here. You're not going to be penalized if you left some time, but just remember, if you run out of time and you haven't mentioned and covered everything, especially the things that are mentioned in the instructions, then this is where you're going to lose. So try your best to adjust your time to what you wanted to say. But if there is time left, I would say it's safer to leave few seconds or the last minute, and it's fine because they will just tip in. Either they prompt you about something or they ask you and you elaborate on something. Just try not to use all of your time, because then you are at risk of running out of time without mentioning the important things. That makes sense.
Yeah, it makes sense. Thank you very much.
No problem.
Any more questions? If no more questions, we can always have questions at the end. Anzad, are you ready to have your mock?
Yes. Hi, I'm Anzad, one of the ST6 trainees in East Midlands, Leicester. Thank you for giving this opportunity. Thank you, Ayat. She's my old friend. I'm seeing after long years.
Nice to see you, Anzad, and thank you so much for volunteering for this session.
Thank you, Dr. Nadir and Rawia, for your guidance and support.
No problems, Anzad. Thank you for volunteering. So next is the second mock session. So this is the scenario. I'm going to read this because it's 2 pages. Ayat, you can start the timing. So again, you are a newly appointed consultant. The task is discuss your strategy for how would you manage your team. So you are the on-call pediatrician for the evening. So this is in the evening. You're not being on the ward in the morning. You came to CAU and you have your evening team, which are a GP trainee, an ST4, and a senior nurse. And you've got the CAU board as follows. So this is CAU setting, okay? You had handover for the ward, but this is about CAU, okay? Okay, I'll let you read, and then we will talk after the time of the reading finish.
4 minutes finish.
Hello, Anzad. This is Nadir. I'm your assessor today. Please tell me about how you're going to manage your team after this handover.
So I've come into the CAU. I would thank the outgoing team for the handover of these patients and keeping the fort till from the morning. I would go have a quick safety huddle with the nurses and the team before they leave about any issues not limited to staffing issues, safeguarding or infections or any date access or any other issues in the ward. And then I would prioritize things. So in the list, I can see around 7 patients. So my concerns are a few of them in the beginning. So I can see Mika was a hemoglobin of sickle cell with hemoglobin, very low hemoglobin, and complicated by the family history of being Jehovah's Witness who usually refuse the transfusion. So this child is a ticking time bomb because of the background. So they can have many complications of disease as well because of the infection now. So these parents needs quick discussion regarding how to go forward. And I should, if I'm a DGH, I would talk with the transport team or the tertiary team as well, or escalate to HDU because this child might need transfusion in a controlled place if they agree. If they don't agree, then we have to involve maybe chaplain or sometimes a legal route also to save the life of this child. So this will be my strategy for this patient. So I will have a quick chat. While I plan that, I would tell my ST4 doctor, as a registrar, to deal with 2 of the cases in the ED, which are also slightly concerning. One is more than the other. First, one patient has not been seen who has a GCS, low GCS as well, and he's in hydrocephalus with VP shunt. The risk of a start infection with a fever is high and can also have abscess or anything. So I would ask him to go and assess first, and if he's happy, and then do an urgent CT and involve the neurosurgery team, which is maybe tertiary team, quickly if there is any concerns in the CT. So that will be I will suggest this advice and then look at the other child with seizures in the ED. I can understand that he has been having some treatment and I think he's progressing. As the parents want everything, we should at least, because it's a chronically ill child, we should look if he has a seizure plan in place. Most of them might have. So we follow that plan from the neurology team, or if there is none, then we follow the APLS guidelines for the seizures. So that would be, and I would say that after talking to these parents of Mika, I would quickly catch up in the ED to make further plans about these 2 patients. The other patients, which is down on my priority list, so I will ask my GP trainee if he'll be comfortable to assess the child with viral gastroenteritis first to see if he needs any IV access or cannulation and IV fluids, because he's on oral feeds and nurses are concerned. Always we take nurses' concerns seriously to see if there is anything which can be done for that. And then I would ask him to look at to talk to the parents of Hala, who has an UTI and mentions previous UTIs. So I would like to, like the GP, I will ask if he could be happy to look at the previous reports to see if it was really culture positive UTI, and if it was yes, was there any investigations done, or should we make a plan according to the NICE guidelines if it has not been acted upon earlier. And as parents, doctors being parents, there are 2 ways it can go. Some of them are very calm and they can they take guidelines as they can be very calm and composed, but some of them can be very anxious. So if they are worried, I'll always be on support to help the GP trainee talk to these parents and deal with them after that. The next one will be the RSV bronchiolitis. This baby is actually very comfortable on nasal cannula, oxygen and IV fluids. So the need of feed is not very urgent, but needs tackling because this child can be very hungry and crying and irritable. So after this, I would assess this child, see if he needs a feed, or I like ask the GP trainee to do that, and then I'll have a hi to these parents to make them comfortable as well. The last one, but not the least, is the HSP child, and that with the traveler's parents. This I want to make sure that this diagnosis is HSP, because even non-accidental injury with bruising can present like an HSP. So I would personally, I will ask, because they are travelers, we might not have history from the social services, or they might not have any GP regular. So I would ask the senior nurse to have a chat with the family and see wherever they have gone, and is there any indication of any other things, how the family dynamics is, what other children are there. And then I would personally have a look at this child to see if it is a pattern of HSP or otherwise, because I can see there's a normal BP and urine. And if we are not concerned about any safeguarding, then I would print a, I'll ask the GP trainee to print a HSP follow-up guide and give the parents and clearly explain where in the first few weeks you have to have weekly follow-up, and the next two by any 2 weekly follow-up will be usually the pattern. So they have to go wherever they are going, they should have this follow-up. So I think this will be my strategy of planning for these patients. I think I've included most of them. Yes.
2 minutes left.
Okay.
Right. As I understand that I don't have to do a ward rounds, but I would make sure that if there are any concerns raised to the senior, I will ask the senior nurse if there's any concern regarding any of these patients. I would like to have a look at them, and I would go and make sure that I support my ST4 trainee and the GP doctor well over that to make them comfortable. If they are going outside the comfort zone, if they are worried about anything, if they are not comfortable, I would definitely go and do that, rather than pushing them beyond their limit.
Okay, Anzad. So which patient are you going to see first?
I'm going to talk to quickly talk to the Mika's parents first, and then go to the ED to help my ST4.
Okay. And you mentioned that you're gonna send your ST4 to see 2 patients. So you ask him to see Dylan and Elijah.
Yeah, first
Dylan
I will ask him to,
yeah. So Dylan
Please.
is in ED resus and Elijah is in CAU. So which one you want him to see first?
I think we should see Elijah first. ED resus, I think the team is already there. Somebody is with the patient, and he is being monitored. So we have to have a follow-up plan for this patient who is already having treatment control. Elijah has not been seen. We don't know what we are dealing with. So he has to see Elijah first, as I mentioned. And I would say with these 2 patients, if he has seen, I would do a leader CBD with him for him as a trainee.
Okay, excellent. You mentioned that, Owen, the travelers, you mentioned about the safeguarding, all the other bits. The question is, because they are travelers and they don't have a regular address and they don't have a regular GP or continuation of care in the community, how are you going to follow them up?
That is really tricky. So that's why I said I would give them a follow-up plan to explain to them. I would ask, probably I can ask where they are going next, so that I can contact those region people and ask them to have a follow-up for this child. It's the maximum I can do, I think. I don't know more than that. Sorry.
8 minutes finish now.
Thank you.
Okay. Well done, Anzad. Well done. It is really, really tricky. So all the handover stations, they will have tricky cases. I don't think that you will see. Sometimes you will see this kind of handover in normal life. But the reason that they do it this way is they want to make sure that you make sure that you know that how to deal with the stressful situations and how to prioritize things. So my feedback to you, you've done very well. You gave me a clear plan for everyone on the list. You know the priority of the patients. You know which one need to be seen first. With the parvovirus, with the Mika, who's the parents are Jehovah's Witnesses, you just need to clarify. So in this time of in this world, you don't need to assume anything. So Jehovah's Witnesses, they might want they might not mind having blood transfusion. They might not be strict. They might not have follow the religion strictly. Some Jehovah's Witnesses, if they can be flexible, some of them not. We don't need to assume. So we just need to talk to them at some point and see what their views. The question is, if this child, so the main thing that you need to do is to assess the child and see if there's any urgency to treat them. If they're clinically stable, they don't have heart failure, they don't they're not hemodynamically unstable, then this is another ethical dilemma that you need to deal with. And I don't think a quick talk will deal with the situation. It will take a bit of time. So if they refuse the transfusion and the child is unwell, you can't transfuse unless it's life-saving. Okay, so you can't do anything. So most of the time with these cases, if they refuse the transfusion, you have to sit down and either convince them or ask the legal team or to have a court order or something else, that if you think that he really needs it. Okay, and there is I think if I stop sharing, I can show you. I think I found something. Just bear with me a second. Okay, don't know if I'm gonna just try and share this. This is from Scotland. Okay, don't know if you can see it or not.
Yeah, we can see.
So this is you'll find it on the internet. So refusal of blood product in pediatric patient, regardless if it's religious, is it something that parents are not wanting to have. You just need to go through all this algorithm. We assume that Micah is young, so he's not competent to make decisions. So we're going through this way. Parents, they are the decision makers, and they have refused. So you need to document clearly they have refused having the bloods. Okay, and then you have to make a decision. Okay, so you can either have if the blood transfusion is not essential and there's other treatment available, so you can start him on ions infusion or something else, buy time until things happen. If that's not the case and the child is really needs the blood transfusion, then you need to go through the other scenario. So if it's elective, that's something else. So you're just gonna need to go through the legal route. Okay. If it's urgent, you can't do it unless you've got some sort of legal cover. If it's life-saving, you give the blood, but you're going to need another colleague to come and help you. So you need 2 consultants to sign, and you need to document clearly that you're going to need to give this blood despite that the parents are not happy. Okay, so it's an ethical minefield. So if you go and talk to them first, you might be dragged into lots of things, and you've got some sick patients that you need to deal with. I'm not saying you don't need to do it first. As you will see later, handover is very subjective. Everyone will have their priority. Okay, but just to be mindful. You've got then Dylan, who is in resource. You said that you're going to send your SD4. That's well and good. They're going to go through the pathway. You just need to make sure that they've got ACP in place because they've got degenerative disorder. You might need to speak to your palliative team to come and speak to parents, you might need a familiar face, because sometimes parents will listen to familiar faces and familiar people, okay? And then you go through the route. If there is on his ACP or on his ACP there is a plan for intubation, ventilation, PICU admission, then you might need to speak to the PICU if you've got local PICU, or speak to the transport team. And the last one that you mentioned that you want to be seen urgently is Elijah, who is a hydrocephalus. Rightly so, you said that you want to do a CT scan on him because he has reduced GCSES. Just be mindful, make sure you've palpated the valve as well, because he has VP shunt. Make sure that you've got documentation that it's not obstruction, it's not infection, it's not anything else. You might need to start him on IV antibiotics if you think it's infection as well. So just be careful, because he has fever as well. So you need to mention that you need to start him on IV antibiotics as well to cover for infection. Yeah.
Yeah. Thank you.
Any more input from you, Rawia? I'll stop talking.
I just wanted to reiterate 2 points about the time again. Everything is automatic. So you're going to be taken from a station to a different station automatically. It doesn't matter whether you finish talking or not. They will take you through to the next one. Just take care of yourself. Try and not look at the time all the time, because there will be a timer within the station. But when they say there's like 1 minute left, just try and think of how to close it. When there's 30 seconds left, there will be a ticking watch there saying 30, 29, and so on, counting down. I would say try and finish before they take you through while you're still talking, because that will just not sound right for the assessor. And the other thing, it will then set you off negatively for the next station. So try just to time it, even if you haven't finished. In the last 10 seconds or so, just try and close it off. This is the first point. The second point, that the point Nadir has mentioned, is sometimes the handover sheet will sound just unrealistically complicated. And I think the aim of, obviously, of the assessment, they want to reach your limit, just to know how far you can go. They want to make sure that if they throw you into a ward and you are the ward consultant, you're not going to panic and run away. So basically, try and stay calm and composed. This is the same assessment that everyone else is going through. Try just not to obviously miss the important big things, but even if it's unrealistically complicated and unrealistically short-staffed, that might also happen in real life, and they wanted to test your limits. You can openly mention that I have really short staff. Is there any way I can recruit any more people to help? Because this is what they want you to hear you saying. Is there any way I can speak to the on-call manager and see if they can get anybody to help? So this is the point I wanted to highlight. Thank you.
Thank you.
Really, really very good, Anzad. You've covered most of the things very good. Thank you very much.
Thank you. I think we've got one more. I understand we might run a little bit out of time. If people are happy for us to just try and go through quickly. We've mentioned the main tips about everything we need to mention. To be honest, it's very subjective, but I want you to be reassured. All the assessors are going to have a benchmark meetings before they start to assess you. And if we give the same scenarios to 3 different consultants in real life, they will have 3 different approaches to the ward. As long as you are safe, as long as you have a plan, and as long as you know exactly what you're doing, that's absolutely fine. Don't worry about having a different view from another candidate. That's still okay. As long as I said, you've got your basics all done. We're just going to go through this one. We're trying to be quick, so we'll finish it off on time, hopefully.
Don't worry, Rawia, about the time. We are all time, but we can short, if Buran happy, we can reduce the 4 minutes. If she's ready, she can go and she can start.
If you give us permission, Buran. So you are always going to be a newly appointed consultant. You need to discuss your strategy of how to manage your team. You are the consultant of the week. You've got like an ST2 who's is taking over. It's got ST2, ST5, and a nurse in charge. And you've been given this attached handover sheet. So we can do it as a 2 minute if Quran is happy. Okay.
Can you hear me? Can you hear me?
Yes,
yes,
we can
we
hear
can.
you, but it seems to be like mute, Bran. Are you mute?
It's a
Yeah,
bit
can you unmute me?
muffled.
I couldn't unmute myself.
We can hear you. It's a bit muffled. Maybe either you speak up or just
Let
look
me
at on your
unmute.
settings
Yeah,
to see.
now we can hear you, Bran.
Oh.
Yeah.
All right. Thank you. Let me know when the 2 minutes finished.
All right. Or you can take your time, Bran. I will not limit it as 2 minutes. If you feel like you are ready, you can just start it. That's all right.
Go for it, Quran, if you're happy.
Thank you. I can see that I have the charge nurse. I have the charge nurse. So it's best to start with listening to a brief from her about the last night, if there are any other safeguarding concerns beside the child that I have is already on the handover sheet. If there is any issues with staffing, if there is any critically unwell child in ED who is or a child who's awaiting to be admitted to the ward, or the bed situation, any other issues that the child nurse want to highlight. I will then thank the night team for their efforts and wish them a safe drive home. I think the night registrar who handed over to us is a locum registrar, so I will tell him that I'm happy to sign off his local sheet, so the locum sheet. Then looking at my team and at the patients that we have to see, I can see that I have the charge nurse, the ST2, the ST5. There is a good mix of skill sets, but I will just reiterate to them the message that I know they may have different competencies. If any of them felt that the task delegated to them they are not comfortable with, to come back to me and tell me. I'll always be happy to support. I will also tell them that we will huddle in 2 to 3 hours and then take things from there. I would love to do a ward round and see everyone, but there are 3 or 4 patients who are quite unwell. So we will divide and care and then re-huddle and do the ward round together. So regarding my patients, maybe in the huddle later, we can do some teaching about the learning points and answer any questions, academic or medical questions. Regarding the patients, I can see there are 3 or 4, as I said, who are a medical priority and quite unwell. There is Wesley, the child with poor asthma. I think the ST5 will be competent to see. I will ask my ST5 to go and see the child, follow the protocol. Just a quick note that to bear in mind that the child has aminophylline, so it might need aminophylline levels. The PUs are written as high, so I would like the ST5 to assess the child and see why the PUs are high. Is this just a tachycardia from medications, or is it a child who is unwell? And if you are in a DGH, does this child need a transfer? Does they need an HDU? What are the setup that we have? Just because if the child needs a transport, we have to start this process early. I will ask the ST5 to bleed me or reach me on my work mobile if she felt that the child is unwell or needs a transport, so that we start that process earlier. If you are in a tertiary hospital, I will ask the ST5 to talk to PICU team. This is about Wesley, the first of the unwell. I'm a bit concerned about Ali, the child with nephrotic syndrome, because there is he didn't read. That can be hypovolemia, that can be acute pre-renal failure, it can be anything. I would like to see him, and I want to take the ST2 with me. That would be a very good learning case for him or for her. But before going into that, I can see that there is a child who needs safeguarding assessment from the night team. This is not urgent, but I have to start the ball rolling. I have to start the process. I have to break the bad news to the parents. So I will let everyone know. I'll go and speak to parents, give them some leaflets, tell them that this is the case. We have to just make sure the child is safe. Just it might be the blues might be still be due to a medical cause, but we'll start the process. I will ask the child nurse to contact social care and come back to me. And I can later, after the social care are there, after parents have read the leaflets, I can come later in the afternoon and do the safeguarding history taking and all, follow the protocol. Having done that, I will ask the ST2 if happy to go to see the child with HSV encephalitis, the child who need a line. This child is HSV encephalitis might need a long course of acyclovir that I can see he missed overnight. ST2 if happy to go and try for a cannula to do that. If they find that it's difficult to escalate to ST5, both of them, if that line is not doable for them, to alert the interventional radiology or anesthetic or pediatric surgery, depending on the setup or the kind of hospital we are in, to please insert for us a definitive PICC line or midline. Having the ST2 did that, I will take them, as I said, to the child with nephrotic syndrome, see it together. Full assessment is his hypovolemia, blood pressure, refill, fluid balance, everything, user needs. And then I might need to talk to tertiary nephrology consultant or any of my senior consultants regarding the HAS infusion. I need also to just exclude peritonitis and ascites from the differentials. Those are the different patients. I think by then we'll do a quick huddle. We have to see where are we. We have few other patients to look at. Layla, the child with, the DKA child, Cassandra. I want the child nurse to ensure that this child is known to the diabetic team. They know that the child is here. I will talk to the diabetic consultant, ensure that they know the child. I need to know also if this is a new child, new diabetic or known to the team, what were the triggers if they're a new diabetic child, what were the trigger for this. Parents have many questions. Teaching is a very important part of a child with diabetes. They have to stay till we can go and properly sit with them, answer all the questions, ensure all the teaching, all the dietitian have seen them, all the injection sites and everything have been really mastered by the parents before sending them home. But he wouldn't be the first child for me to see. The child nurse and ST2 can see first, and then alert the diabetic team and the diabetic nurse to come and see. Then Lucy, the child with paracetamol overdose, the child nurse can go and stop the Parflex and refer to CAMS. This can be a learning point later, as this is something that can the 19 could have stopped the Parflex, but it will be something later to discuss. Child nurse can take care of that one first. Now, Shaima, I wouldn't, the child with abdominal pain, I don't want to send any of my team to go and speak to the parents because it's written that they are pushy. I will just apologize to them that I will come and see their child later, but for now I will take care of the medically unwell children. When I go later, I will do full assessment, history and examination.
1 minute left, Quran.
Thank you. When I do later, we'll do full assessment, history and examination to see is it just a functional abdominal pain or is it a sinister diagnosis or even there might be a safeguarding concern in this child. For the child with a viral with Alfie, for now it will be at the bottom of the list. He can be given his inhalers and later assess for the stretch. I will ask the junior, the ST2 to prep TTOs for him and for the child with DKA just after the proper assessments. I'll give the work leave to my team and ask them to contact me if they have any issues. We will huddle in 2 to 3 hours and aim to do a 15 to 30 minutes discussion and teaching. Later, we can talk about the nephrotic child or severe asthma or even the paracetamol overdose. In the afternoon time, I will aim to see the child with abdominal pain and complete the safeguarded proforma myself or my ST5.
What sort of safeguarding concern are you having about the 13-year-old with abdominal pain?
Well, the parents are pushy and the child has so many visits to the hospital. It might be the child have functional stresses, or might be child just want to be in the hospital instead of being at home. This need more digging. The parents are pushy. Are they pushy for more workup, not needlessly, like factitious illnesses, trying to medicalize a child while there is nothing? Or maybe, as I said, I will assess and see, maybe there is a genuine medical problem.
Thank you, Boran. And obviously you automatically go to the next station. Thank you very much for the demonstration. I think you've gone through everything. It's now very clear to all of us. We all try and think as a consultant, and thank you for doing that. You rightly thought about the locum doctor who covered and thanks them. You thought about the nurse in charge and all the safety concerns that she might possibly have. You thought about the safeguarding, and you've gone through the SBAR. So basically, the SSS handover tool, your SBAR, your safety, and your safeguarding. Safety, obviously, including staffing from medical and nursing. I don't want to go into details of your patient management. You've done that correctly, I think. There is, again, no right and wrong. It's important just not to miss somebody who is really significantly unwell. And that can easily happen because it's just the screening time. The 4 minutes is realistically short. And I'm glad that is not going to happen in real life. You have half an hour for taking your handover appropriately. So obviously the outcome of everything is either you get a satisfactory outcome, you can get a needs improvement for remediation. Just be reassured that the remediations for handover is always just doing a hat most of the time, which is easy to do. Even if you miss something and they wanted you to improve on it, do a handover assessment, put it on your PDB, and you're done. So hopefully that should be it, even if you have some remediations. Even if you've got a satisfactory outcome, they always want to give you areas for improvements within the comments. That's fine. Just read them. Make sure that you've put something in your portfolio before your CCT, and that's it. I would say don't worry about the significance concern bit. Very unlikely. I haven't heard any of my patch or previous or before me patches that anybody has a significant concern. If that is risen, there will be meetings about it. There will be assessment to see if this trainee is actually concerning in every other aspects. It's not a light decision to take. So I wouldn't be worried about it. So generally just be reassured. Hopefully your screening time is going to be enough and you're not going to miss any sick child. And that's it from me. Thank you.
I'm not going to repeat the same thing that Rawia said, but again and again and again, handover is very subjective. Handover differs from a consultant to another, differs from a trainee to another. I might have a patient that I want to see first. Rawia might have a different patient that she wants to see first. The most important thing that you just cover everything and you ensure that you are a safe doctor and you're ready to become a consultant. All of us have done the start assessment. All of us had start PDB. All of us have remediated. It's just part of the training, and you're gonna go through, and just stick to the few things that we've said today, and things will be fine.
Thank you so much, Nadir, Rawia, Brian, and Anzad. It is like a wonderful tips, and I hope everyone will get the benefit from this session today. This session is recorded and it will be in the British Sudanese Association of the Paediatric and Child Health YouTube channel. And please, there is a feedback form. If you can fill it and you can put it, if you have any question, you can put it for the future session. You are welcome, or you can reach me. And if you have any question for Rawia or Nadir or everyone, just unmute yourself and speak. Anyone got any question?
I sent everybody to silence.
Hello?
Hello.
Can you hear me?
Yeah.
Yes.
Yeah, no, just no, thank you very much. Actually, yeah, I mean it's a bit tricky sometimes. They had the handover list. I wonder if it's a good idea maybe to always remember that we've got also, you know, the anesthetic team, maybe that we can ask if there is any breathing problem, and we are really stuck with a lot of sick patient. Probably I will send my registrar and also maybe ask for anesthetists to review the patient and also to communicate after gas, maybe with the STRS to get some advice. Also for line, as you know, as access as well, anesthetic. At least in my hospital, they are quite helpful if nobody can get a line. And no, my doubt is really, we always have got this senior nurse with us, and I would like to make the most, you know, to use it, to use her skills. But I'm always in doubt of, you know, it looks like we don't really use their skill to help us. Yes, we communicate with them, we ask their concern, but what can we ask them to do actually? Like, how far we can? Is there any advice about that?
My
Thank
advice
you,
to you,
Nadir,
Nadia, sorry.
for both points that you've mentioned. I'm glad that you said in my hospital that's so and so. It's different in different hospitals. I would say the best way of doing things is to check. For the first point, there would be a different escalation plan in every hospital. Know your team, know who are you getting to get when you put a pediatric fast bleep. Some hospitals, they have ITU, some hospitals have PICU inside. Some hospitals have HDU. So I would mention, I need to know my team, basically, and who is going to be available to help. Again, in the second point, regarding the nurses, always check what skills they have and are they allowed to use it. Some nurses, they know how to cannulate and they know how to take bloods, but the policy is for the doctors to do it. So I would say, just check all the time. Sorry, Nadia, if you've got anything to add.
No, you've said what I was going to say. The same message. Knowing the team is very important. Knowing your surrounding. When you go through the handover list, just give all the options that you can. So say if I'm in DGH hospital, I will speak to the transport team for an HDU patient or PICU. If I'm in a hospital which has HDU or PICU, I'll speak to that team. So the HDU and PICU team. So just make sure that you cover everything. So when you don't leave gaps or things that they can feed back to you, but you will always have some sort of feedback anyway. With the nurses, with nurse in charge or any nurse on the ward, you can always use them for communication with other teams, with referring to social services, with contacting people, even with contacting other consultants. So if you're short and you think that I've got a safeguarding patient that I need to deal with and I need to do things, and I've got someone else that I need to deal with as well, and I can't do them together, and they are both urgent, you can speak to the nurse in charge and see if she can speak to the consultant who's on CAU or the other consultant who may be in their office, just to raise that. In the real life, we all have WhatsApp groups. We can just go on the WhatsApp group and speak to the other consultant, or we know who is available today, who has clinic and who has not. But just like a general rules, communication, anything that you don't need stethoscope or need to do anything like cannulas and stuff, you like speaking to other teams, you can use the nurses for.
Thank you very much. And one last question, sorry. You know, this traveler family that we had before, I mean, it's very tricky because they can be around, they can disappear. I'm not sure if they are coming. And I think we have got, you know, a responsibility also towards this child, even though it's a family that is traveling. So can I ask, would it be a good idea to ask them maybe initially, first of all, to make sure that they've got a GP, and if the GP can, you know, get in touch with them. Or if they don't have a GP, maybe they should come to the day unit initially for an assessment, initially to make sure that everything is okay. And also, can we ask the community nurses to visit them?
It is very tricky and very hard with travelers. Very tricky because they don't stay in one place. They move from place to another. I think the best thing for this child, if you think it's HSP and you just need, so with HSP, what you need to do, you need to check for proteinuria and maybe check for blood pressure. So if you teach them very well, you give them urine strips, you teach them how to check for protein, and maybe arrange an appointment with you in the clinic.
Yeah.
Just like a safety netting. So they need to know how to check the urine, and if there's proteinuria, if they develop like joint pain, joint swelling, blood in the urine. So safety netting as we blood in stool, sorry, safety netting as we always do. Give them some sort of like red flags that they need to come back to the hospital or go to the hospital that they are going to. Very good teaching, and then offer them the appointment. They might not be in the vicinity of the hospital. They might have moved to another part of the country, but give them that opportunity and make sure that you have safety netted them.
Thank you so much. Thank you very much for your advice.
I think we've got Dakuro as well. Dakuro.
Thank you so much. Please, I have a question. Like when they use abbreviations, if they use any abbreviations that you do not understand, are you allowed to ask what that means? Please?
Yeah, of course.
Thank you.
We're all guilty of using 3-letter abbreviation in our in our life. This is the problem, I think, that we are all getting into. But please clarify whatever you don't know. Please clarify. I know I've said that it's a monologue. It's one-sided. You're gonna just talk and they're gonna listen. But if you don't understand or you want them to clarify something, you can ask them, because he said I can't answer this part unless I know what is this.
Thank you.
Thank you so much for all your question. Anyone else have a question? If not, thank you so much for your coming today, and see you in next session. It will be on the 1st February. It's about the teaching and also tips about start in general.
Thank you.
Thank you, guys. I really enjoyed the session today. Really enjoyed talking to you guys, and I hope that you find it very useful. Keep well and take care.
It is really very useful. I hope everyone will be happy and learn a lot of tips, new tips today. Thank you so much.
All the best.